All right, so welcome everyone to the EGFR breakout. I am John Sherrill. I am a stage 4 lung cancer survivor, diagnosed January 2016.
Just got married this week.
Just got married last weekend.
And you survived it. Yeah, I'm still tired.
I just had an itinerary to show off.
That is true.
So I guess I'll do my story a little bit. So I started probably with bone pain was probably the first indicator for me. Lower hip was probably the worst. Brushing it off. I played soccer as a high schooler, jumped off things that I shouldn't have jumped off of, broken bones, stuff like that. So kind of pushed that pain away. Thought nothing of it. Probably about 3 months later, November-ish, developed a cough. Went into a MedExpress. Here's some antibiotics. Here's some steroids. You're gonna be fine. There's nothing wrong. Cough came back 2 weeks later. Went into another MedExpress. We didn't try this, so here's another drug to help with the cough, and there's some haziness, and here's some wheezing, so probably infection or something. Cough came back. At that point, I started to get night sweats, chills, fever at night, really bad fatigue, and that's when that same MedExpress doctor said, if something's getting worse, we need you to come in. I went in for a CT scan on his recommendation, and didn't even get out of the CT facility, and I was getting a call from my PCP that he needed to come in right now. And remember my wife driving an hour because that call, it's like, okay, something's going on, and got a doctor, and he's like, said the C word, you have cancer, and I was like, well, where is it? I was like, from the scans everywhere. At that point, we were in for a chest CT because we only did lower abdomen for what was having the pain and stuff like that. Chest CT found a mass in my lung, upper left. And at that point, I think I was going in for a biopsy on the bone because they were thinking it was leukemia or lymphoma or something like that at this point. Did a biopsy of the bone, found out it was lung, and then very quickly, through my wife, who knows Matt Hisney's wife from childhood, got in contact with Matt, who got in contact us together, and came up to see Dr. Pennell here. And I think at that point we had the results that it was lung, and we started the genetic testing. And I'm pretty sure the first day I met you, you told me I had to go get an MRI because it was pretty sure that we had brain mets. And we found 4, did Gamma Knife once, and I think the day after Gamma Knife I started afatinib or Gilitrif. Got 12 months, 14 months on Gilitrif, and liquid biopsy, T790M positive, so I'm happily been on Tagrisso since April. She has all the notes from me. Trying to think. Had 2 treatments of Gamma Knife. Different palliative treatments on bone, hip, rib, mass in the neck a couple weeks ago that we found. And then, as of last week, some spots on the spine that we're going to treat with SRS. So, I think that's my story.
30.
Oh, yes. Yeah. 30 now.
Yeah. It's interesting. It's the patients with EGFR and ALK. First of all, I was struck by the young age of so many of our panelists, and in general, I think that makes it a real curveball. That it's not your disproportionately younger patients often with little or no smoking history, would come in with a cough that the ER physicians would think, wow, this must be cancer. It's not. Who's thinking that a 30-year-old with a cough has cancer?
Right.
But so it usually takes a little while longer to make that diagnosis.
And when it does appear to be cancer, lung cancer is not the first thing that you think. So both you and Matt, were told that it was likely something that's more common in younger people, like Hodgkin's disease or something like that. And so it's got to have been, so what went through your mind when you heard it was lung cancer? What was your...
At the time, I didn't know really the difference, of what lung cancer really meant. I knew it was worse because I saw, that leukemia was, 6 months of chemo or something, and, there's good results. But from lung cancer, you hear bad things. So I think at first I knew it wasn't good, but I didn't realize the full complexity of what lung cancer meant.
Do you want to start here?
Yeah. So I'm going to give a little talk, just kind of a background on EGFR mutant lung cancer, and go through some of the evidence for our options for initial treatment, and then Dr. West will talk a little bit about subsequent treatment and resistance, and then we're going to go into some of the very new stuff that honestly we're talking about like last week, new stuff.
Amazing things that literally at this moment in time a week ago were just being presented.
Exactly. So a lot of this stuff the people in this room probably already know, but I'm going to go through it just because I like to. I think it's a really interesting story. The history of EGFR mutant lung cancer, the data behind the first and second generation inhibitors, and how do we decide as doctors which one of these we would pick. So just to go back and think about the history of how we treated lung cancer not that long ago. Really, I've only been out of fellowship for about 10 years, and so when I first finished my fellowship, we were just starting to get out of the era where we thought of lung cancer as really one disease. In fact, non-small cell lung cancer, it doesn't even tell you what it is, it just tells you what it's not. So I wish this name would go away, but everyone was treated the same. And so the idea was, we knew that one size didn't fit all. We knew that there was a mixture of smokers, non-smokers, older folks, younger folks, different clinical presentations, adenocarcinoma, squamous cell carcinoma, but everyone got the same treatment. And we knew that a relatively small number of people benefited from these treatments. Everyone got the same side effects, and then that was pretty much it. The idea today, though, is we're doing a much more biomarker-driven treatment, trying to separate out from the mix of different types of cancers into different individual cancers. These are all actually different cancers. EGFR mutant lung cancer is its own disease. It's not a subtype. I mean, it's a cancer all unto itself. And by doing this, you actually direct people to treatments that work better and potentially have less toxicity. And so in 2017, instead of one pie for everything, we actually have oncologists, if you haven't told, love graphs and pie charts and things like that. I love to separate this out now, that there's tons of different types. These are just the ones that have, say, approved agents associated with them. Fully 50% of people with non-small cell lung cancer now have a treatment other than chemotherapy as their optimal proven first-line therapy, which is pretty extraordinary. And all of this started with EGFR mutations. This is what started off the biomarker-driven testing to try to identify people for better treatments than chemotherapy. So we're going to go back in time to the turn of the century, back when I had some hair, and take you to the development of the EGFR drug. So the human epidermal growth factor family of receptors includes EGFR, but also HER2, and HER2, of course, is very prominent in breast cancer. But we knew that EGFR was really ubiquitous on all kinds of epithelium, and it was very highly overexpressed in lots of different types of cancer, including lung cancer. So they developed a number of inhibitors to the EGFR, and they tried it in lung cancer patients. And so this is the way trials were designed around 2000. You would take all lung cancer patients, smokers, non-smokers, squamous, non-squamous. They had prior chemotherapy. There really was no next available treatment after your initial chemotherapy, so it was still okay to do a placebo-controlled trial back then, not so long ago. And half the people got Tarceva and half of them got a sugar pill. And this is what qualified as exciting back in 2005 when this was published. A 2-month improvement in overall survival on average for everyone who got this drug. But that really wasn't what was exciting about this drug. What was exciting about this drug was it was clear immediately, not just from this trial, but from all the EGFR trials, that there was a group of people that were different than everyone else. There was a group of people that were having dramatic responses. They were getting better within days of starting on the pills. And then there was the bigger group of people who maybe they got some benefit, but it was much more modest. And it turned out they were more likely to have adenocarcinoma. They were more likely to have either never smoked or a very light smoking history, more commonly women, or Asian ethnicity at the time. And so this is just a breakdown that was presented back in the day, looking at the difference between never smokers, for example, versus smokers. And the light blue line is the Tarceva and the dark blue is placebo. You can see in never smokers there was a huge difference in survival. So this was what we call a surrogate marker. It's something that kind of indicates a different group, but it didn't tell us what that was different about them. And so just to jump forward, this is Alice Shaw's group now, although I'm not sure if she was even out of fellowship when this came out, but they had discovered that they took the tumors of patients, biopsy tissue of those who'd had these dramatic responses and sequenced them and found that there were these recurring mutations in the epidermal growth factor receptor, tyrosine kinase domain. That's the active part that signals when it's on. And they had essentially the same mutations, all the people that were responding to this. Believe it or not, despite the fact that this happened, there was a big group of people that were skeptical that this was important. They said, oh, sure, these maybe are a small number of people who are benefiting, but in fact, we still think it's a larger group of people who are benefiting from these drugs than just the mutants. So we did, after a number of single-arm trials and retrospective studies, identify that EGFR mutations were present in about 10 to 15% of people in the U.S. with adenocarcinoma. If you took just never smokers, it's about 40%, and if you go to Asia, it's about 60% of never smokers. And these drugs, the first-generation drugs, Tarceva and Iressa, or gefitinib, had high response rates. You can see a patient there before and after with very nice resolution of most of their agents. But of course, it also didn't work forever, and patients would eventually progress. So we knew that even before these drugs were approved for EGFR mutant lung cancer, that this is what happened. So this has now become kind of a historical trial, but I like to still highlight it because, in my opinion, this is probably the most important trial that's ever been done in lung cancer. Not so much because of the results, but because of the thinking behind it. It's called the IPASS, the Iressa Pan-Asian Study. All of these were Asian adenocarcinoma patients who'd either never smoked or who only smoked a little bit, I think fewer than 100 cigarettes in their lifetime. And half of them got Iressa, and half of them got chemotherapy. And this was based, again, on just the clinical characteristics of their being people who had never smoked. But they did do mutation testing along with some other things in as many of them as they could. And this ended up being the result. And this is what is really cool about this. If you had a mutation, the green line, so remember we talked about this. So at time 0, 100% of people are alive. I'm sorry, this is progression-free survival. So 100% of people had their cancer not yet growing. And then as you go through time, the line goes down as patients' cancers progress. And what they found was if you had a mutation, if you got Iressa, you had a much better delay of the cancer getting worse than chemotherapy. But if you did not have a mutation, despite having adenocarcinoma and never having smoked, chemotherapy was much better. And in fact, if you look at the timeline here, most patients, by 4 months, 90% of them, the cancer had already gotten worse. It didn't work if you didn't have the mutation. So this was the first proof that it was actually a gene, an actual mutation, a biomarker we could test for that was indicating who would benefit from this drug. We now take this for granted, but before that, maybe in breast cancer with estrogen receptors and things, but in lung cancer there was nothing like this before.
So just to, sorry to interrupt, but to
Yeah.
put it in context, this, I agree, was an incredibly important study with this result for a few reasons. In fact, I wrote, it's interesting to look back at, because some of these are such old history that
Right.
I've forgotten them, and they're like 4 laptops ago that I
Right.
had them on my, I just don't show them anymore. But I think you can go back to the historic record of like the things I wrote in late 2006 and 7 and 8 in Grace are like, you know, an archive of what the world thought at that point. And it wasn't, you know, we knew about the mutations, but they were not easy to test for or routinely done. And the big question was, can you just do as well by saying all never smokers should get EGFR inhibitors?
I think there was this West guy who thought maybe it was bronchoalveolar carcinoma.
But there were you know, certain features, and it was really a question of, should we just enrich by the clinical features, which was the design of this trial. This was 1,200 Asian never smokers with an adenocarcinoma who were, when we were trying to convey this is somebody likely to have an EGFR mutation, you would have a patient, an Asian never smoker with an adenocarcinoma, and everyone thought, okay, I get it. This is someone who did well on Tarceva, right? You know, but that was what they were trying to go for. This was a subset analysis of about a third of the people on this 1,200 patient trial. What it showed, 60% of the patients had the mutation, which means that 40% did not. 40% of the patients who we all thought, oh yeah, this is good, awesome, did not have a mutation. And
the drug didn't work.
And the drug didn't work, and you did significantly better if you got the standard carbo and paclitaxel. So there was a negative consequence to guessing wrong.
Right.
And because of that, I wrote an article, a thing for Grace called, you know, the results of the IPASS trial, Confessions of a Former Clinical Selector. And that was a sea change of, it's not about the clinical features, it all comes down to the markers.
And I forever will have a distinct memory of Paul Bunn, one of the biggest non-mutant believers, standing up at the ASCO when this was presented and saying, I was wrong, mutations are important, we need to test for everybody right now.
We can only know what you know at the time, and it's an evolving field, and the key is just to be amenable, to be open to new information as it comes in.
Yeah.
So, you know, it's at the time, 2005, 6, 7, that was a more viable thought, but you don't want to be so entrenched that you aren't open to it and say, this changes everything.
Right. And now, of course, we know that testing is important, and there are these driver mutations. So what we learned was it's what we call the genotype, not the phenotype, not what the patient looks like, but what the actual cancer shows that matters. And also, that was important, if you think about it, you actually have to be able to test for these in order to guide treatment. You can't just treat everybody indiscriminately, and that raised a whole can of worms. You have to be able to get the right kinds of biopsies. You have to have the infrastructure and the training to be able to do the tests. You have to be able to get the results in a short enough period of time that you can actually start someone on treatment before they get too sick to get any treatment. So it was a big, important thing. So then there were a bunch of trials where they compared both Tarceva and Iressa to chemotherapy, and all of them pretty much showed the same thing, that you got very high response rates, so the measurable disease getting significantly smaller, compared to chemotherapy, much higher, and that the progression-free survival, which is again a surrogate for how long it lasts, was more than doubled by being on these inhibitors compared to chemotherapy. So all of them showed basically the same thing. Interestingly, none of the trials actually showed that people lived longer by being started on these drugs than getting chemotherapy. This is thrown out a lot. I don't care if any. I don't care. I do care. I don't know if people care about this or not, but it is thrown out a lot. This whole never having an overall survival benefit in these trials. And let me be plain. These drugs prolong survival significantly in people with EGFR mutations. There is no doubt about that. The reason the trials probably never showed a difference is that these drugs had already been around. So by 2010, 2011, these drugs had been available for 5 or 6 years, and people who were on chemotherapy, who then got worse, could then get access to them afterwards, after the trials. And so, but the time that people were living, instead of 8, 9, 10 months, we're now living 2 and 3 years on average. So clearly, survival was being prolonged.
But I think it's also, notable that an implication of the crossover, the idea that you could start on chemo and go on to the other and still live the same amount of time, does suggest that it's not a crime against humanity to get it later if that happens to happen. And so you can so-called rescue patients unless the worst thing happened, which is you're an EGFR mutation positive patient and you never get the chance because you're in a healthcare system that doesn't have it, or you have terrible progression in the brain and you decline so quickly. That is awful. But it doesn't honestly matter that much whether you take two blocks north and 3 blocks west, or go 3 blocks west and 2 blocks north. You're going to be at the same place at the end. So.
Right. We use these things first line because they tend to have fewer side effects. They tend to last longer. But you're absolutely right. If you start with chemotherapy and it's working, you can save it for later on. Okay, so those were the first generation inhibitors, Tarceva, Iressa. They became the standard of care all over the world for EGFR mutant lung cancer. Then along came the second generation, so-called irreversible pan-HER family inhibitors. So the one that is available in the United States is called afatinib or Gilitrif. And then there's another one which I sort of newer, even though it's been around for a while, but it's just not available in the United States, called dacomitinib. These are different from Iressa and Tarceva in that they target not just I move this. Every time, I just won't move it anymore. But it doesn't just target EGFR, it also targets HER2 and the other HER family inhibitors, and that's important because they actually pair up with one another, and so there's at least theoretical evidence that might help prevent resistance. And they are what are called irreversible inhibitors, and so basically the Tarceva and Iressa are reversible. So if this is your EGFR, and this is Tarceva. It comes on, it comes off, it comes on, it comes off, it comes on, it comes off. And if there's resistance, maybe it doesn't stick as well. Whereas if afatinib sticks, it's stuck. That's it. That protein is shut off permanently until it's degraded and a new one is made. So again, theoretically, could reduce resistance by doing these, at least in dishes of cancer cells, if that was the case. And so they planned a couple of big phase 3 international trials called the Lux-Lung trials 3 and 6, which were both afatinib versus the best available chemotherapy at the time, so cisplatin pemetrexed in this and cisplatin gemcitabine in 6. And when you added it together, what you found was that they basically looked about the same, really. Your response rate was still in that 50 to 60 to 70% range, and that you more or less doubled or better progression-free survival. There was no obvious advantage from these trials with afatinib compared to Tarceva or Iressa. But they weren't Tarceva, they clearly weren't. So there was then this a lot of talk about a subset analysis from the Lux-Lung 3 and 6 trials where they looked by the type of mutation. So we know EGFR mutations, about 45% of them have a deletion mutation in exon 19, which is part of the gene that codes for that functional tyrosine kinase portion. And then about 45% are exon 21 point mutations, or L858R, and that there may actually be differences between the two in terms of how people do. The prognosis may be better if you have the exon 19, but both of them sensitize to make the cancer sensitive to being inhibited by drugs like Tarceva and afatinib. So what they did was they looked at the survival. So the overall survival, again, no difference between chemotherapy and Gilitrif. But if you looked at the two different types of mutations, what they found was in the exon 19 groups, in both trials, the survival was substantially longer, about 12 months longer on average, if you got Gilitrif than if you got chemotherapy. And that was not true in the other type of mutation. And no one had ever shown this in any other trials previously. And so the argument was, well, you know what, maybe Gilitrif is a better drug for patients with exon 19 deletion mutations, and it doesn't matter so much with the other ones. That was an extrapolation. Okay, that's not what the trial showed. The trial didn't show it was better than Tarceva and Iressa. It showed that it was better than chemotherapy, but to a degree that actually survival was changed. There was an important caveat to this, and that was that this was an international trial. Both of them were international trials, and there were countries that did not have EGFR inhibitors available for the patients to cross over to when they lost chemotherapy. And so there was a debate about, is it truly that it's better in this group, or is it just that this was really the first kind of placebo-controlled trial of EGFR versus chemotherapy with no crossover, and that there was a survival benefit in that. Nonetheless, I and many people started routinely using Gilitrif specifically for exon 19 patients based on this. That was 2014. Okay. 2016, they published a head-to-head trial of afatinib versus Iressa. So Gilitrif versus Iressa. It was a phase 2 trial, relatively small, all EGFR mutant patients. And what it showed, is that, so the blue line is the Gilitrif. So for most of the time the patients were on it, the lines were more or less the same, and then later on you got a little bit of a separation of the curves. It did end up being statistically significant. This is not overall survival. This is, again, the time, essentially, that people were on the drugs. And it appeared that there was a subgroup of people that actually were able to be on the drugs significantly longer than with the Iressa. But it's not dramatic. You know, you guys don't look at these curves all the time in the way we do, but no one really looked at this and said, you know what, Gilitrif looks like it's dramatically better in terms of how long it works compared to Iressa from this. But really what I looked at was the breakdown by the different types of mutations. This is the LA5-8R, and this is the exon 19 deletion. And as you can see, the drug was modestly better in both, more or less equivalently. There was no difference in how well it worked compared to Iressa based on exon 19 versus exon 21. And so I personally think what this showed was that it probably wasn't that Gilitrif is better for exon 19 patients, but rather exon 19 patients just do better on average with treatment with EGFR inhibitors, but that both of them are probably, it's probably slightly better in both, but questionable about how significant that is. So if we have maybe a little bit more effective drug, how does it compare from a toxicity standpoint? So this is my own, wow, that was not a good idea. All right. If you look at the left group there with Gilitrif, you can see that most patients get diarrhea and a rash, and that there's a fairly high number of people who get mouth sores, stomatitis, or paronychia, which are an inflammation of the nails that can turn red and be painful and whatnot. Are you having flashbacks? Gilitrif, yeah. So, and then if you look at a separate trial of Tarceva, you can see that while, yes, diarrhea and rash are the most common ones, grade 3 is what we consider to be serious enough you have to stop the drug and treat it, is much less common with Tarceva. That being said, Gilitrif is an effective drug. Most patients need a dose reduction and more TLC in order to manage these side effects, but there is a meaningful difference between the two in terms of side effects. Afatinib, as a more potent, irreversible inhibitor, has more side effects. That's just a fact. Okay. What we learned this summer in ASCO, to the surprise of many people, including me, was that there was another irreversible inhibitor out there, and it actually muddied the waters a little bit in terms of this. So after all these trials, my conclusion really was that all of the drugs were more or less the same. Yes, afatinib is maybe a little bit better, but maybe not enough that it's worth the additional side effects than Tarceva or Iressa. Dacomitinib is also an irreversible pan-HER inhibitor, similar to afatinib. And they presented a phase 3 trial, again, EGFR mutant patients. Importantly, these patients, none of them had brain metastases. They were excluded. So this is a kind of a good prognosis group. Half of them got dacomitinib, half got gefitinib. And what it showed was actually very similar, at least qualitatively, to what was seen in the LUX-Lung-7, the afatinib, or the Gilitrif versus Iressa trial, which is that patients did about the same for the first 6-9 months, and then there was a group of people that seemed to last longer. This is again progression-free survival, so how long did it control the cancer on the dacomitinib compared to the Iressa. And in about 6 months on average, longer control before you progressed on the dacomitinib compared to the Iressa. Response rates were the same. So it wasn't benefiting more people, it was benefiting people longer. So, where are we now? So Tarceva, Iressa, Gilotrit are the approved and available agents in the United States right now. All of them, I think, are appropriate to be used. There's no clear advantage of efficacy of one over the other. You should never use these by guessing. You should only use it once you've identified an EGFR mutation. And everyone should be tested, although I think it's far from 100% of people who are being tested in the United States. And afatinib and dacomitinib may actually be slightly more effective, but at the expense of more side effects. And so I think if this trial had been done 5 years ago, dacomitinib may actually, based on this, have been a much more promising drug. And we're going to talk a little bit later about why that may not be the case. Part of the problem now is that it's actually been around for a long time. I'm not sure how much longer its patent life is going to last. It's not approved yet in the United States. And, of course, it's got the extra side effects that make people hesitate. So I'm not sure if it will end up getting adopted. And we'll talk a little bit about the new data from Flora.
Great.
Why wouldn't doctors automatically do the testing for the mutations?
So it has a lot to do, I think, with, part of it is education, but I think at this point most people are aware of this. I think it has more to do with the resources available for whether you're able to do the testing routinely, where you are. So in a lot of places what happens is nothing gets done until the patient actually meets with the oncologist for the first time. And it may already have been a few weeks or a month since their biopsy was done. And then the oncologist has to, in their 8 minutes that they have to spend with the patient, they have to talk about all the treatment. They also have to remember that they have to then order that test to be done. So they have to call up their local hospital or pathology lab to do the test, which may or may not do it there. They may then have to send it out to a company to do the test, and then get the result back, get that back, and then bring the patient back in and decide what to do. Oftentimes, there's not enough tissue, depending on what the test was, and then they have to decide if they have to get a new biopsy or not. I would say most of the time you should, but some people would say, maybe if a patient was a heavy smoker, maybe it's not worth it to do it. We know that it is worth it to test everyone, but not everyone would think that way. So it logistically is not as simple as it should be. At places that do universal testing, so at the Cleveland Clinic and in a lot of academic university hospital centers, we have it triggered automatically. So the minute a pathologist says this is a lung adenocarcinoma, they immediately start testing, so that by the time we see the patient, often that testing is already done and available. But that's not true everywhere.
I would say that usually it's a pretty routine thing for patients with a non-squamous lung cancer. The squamous lung cancer, it's not as common, and it's largely because the probability is very low, and it's not clearly as indicated to do that if it's a 1 in 100 chance versus a 1 in 10 chance. I agree with Nate that in the vast majority of the time, it's something that if you have a patient where it's a standard thing to test like a non-squamous, you do. But there are rare patients who, and I think it's less rare if you go further out in the community, where they may just not have a lot of tissue. They don't have as many experienced people at doing the biopsies that get enough tissue to run 2, 3, 4 different things. And sometimes even at the best centers, the biopsy just has very little cancer material. So sometimes you won't have enough, and you need to weigh that desire against the reality that you kind of want to get started on treatment and you're playing the odds. And nowadays, I'd say that liquid biopsies are something that you can do that in a situation where, okay, I'll start them on chemo and I'll check the liquid biopsy at least as a first thing, and I'll get that result within the next 10 days. And if they get 2 cycles of chemo before, one cycle of chemo before we get the results back and we find they have an EGFR mutation, you could still act on that. It's not like never asking. It's just, I think it's a mistake to never ask, but I don't think it's the worst thing in the world to kind of weigh and balance the time consideration versus, because it's not just the time of the testing itself, which is usually several days, but setting them up for another biopsy, getting that read and sent off. That could be a 2 or 3 week delay that you'd want to weigh against the desire to get started. But most of the time we do.
Mm-hmm. Yeah, when I say that it's not universal that it's tested, it's not that a small number of people are tested. I think it's a small number of people that aren't tested. But I think ideally it should be.
Ideally, yeah. I also think it depends on the region. I practice in Seattle. There's a lot of never smokers and a lot of Asian patients, and we see lots of these mutations. And the community-based docs prioritize it accordingly. They always think about it, and you don't have to be an academic center. They know, they can quote chapter and verse a lot of times about these therapies, which is amazing. But if you go off to other parts of the country where it's way more associated with smoking and they rarely see an EGFR out, they might think it's a hoax, and those don't exist. So I think there's pockets in different, in the southeast where they just don't see it, and I think there's more education to do. But I would have to say part of the reason that I had started Grace, back when, and I think there's something also that many of the patient organizations, advocacy groups do a lot of is, make sure you get tested, ask for this, because if your doctor isn't asking for it, they may just be cutting corners, and you want to push against that.
Mm-hmm.
Yeah. So we already alluded to this is a curse. How rapidly things are changing. So I'll speak a little to that. Now, I think most people in the room know about T790M, have heard about it, but for some, maybe not. And this is the basic breakdown of what happens when we get another mutation or another biopsy when the cancer progresses, whether that's months or years after. This is what we see. About 2/3 of the time, half to 2/3 of the time, there is a dominant mutation called T790M, and we largely divide acquired resistance into the 60% with and the 40% without. And as you can see, that 40% without can be a wide range of other things. Some other mutations that we know about, some even have potential treatments. One called MET that is of growing importance. Minority, maybe a few percent, will have a transformation into small cell cancer that has a different pace and is treated with chemotherapy primarily, and some that we don't know. One thing to know about is that there is a possibility of being positive for T790M right at diagnosis. In a Japanese study, they used a super sensitive technique and claimed that a quarter of patients will have this, but that's not been seen outside of that study setting. What's more typical is what's described in the bottom by Helena Yu, and that is from Memorial, where they, out of 2,000 plus cases, saw about a 2% chance. So it does exist. Rarely it might be this familial form. More likely it's just the random development of this acquired resistance mutation right at the time of diagnosis. I've had one patient or two in the last year or so and started them on Tagrisso, and they've done well. But in a pre-Tagrisso world, what we saw was a very rapid drop in, the curve on the bottom basically shows a plummeting down to zero. Patients typically progress within weeks on the EGFR inhibitors that Nate was talking about. Prior to third generation inhibitors, and still occasionally used, would be a combination like Gilitrif and Erbitux, afatinib and cetuximab. These are agents that both target EGFR, which and this is going to be tempting fate here. So the EGFR is a molecule that crosses from the outside to the inside of the cell membrane. This bluish is outside the cell, this white is inside the cell. And the oral drugs block the portion on the inside that goes to affect things inside the cell. Another way to block the same molecule is IV drugs, and that's what cetuximab or Erbitux is, that blocks some of the interactions outside of the cancers, outside of the cell itself. And so there have been trials that combined drugs that block EGFR from the outside and the inside, and you can see from this waterfall plot that a lot of them do have shrinkage. Let me give you a little more. This is a busy slide table. Key point is that the response rate, OR, objective response, major shrinkage, was a proportion about 37% of patients. Actually, I think this is just 37 out of 126. So it is certainly possible, but these responses did not tend to be very long-lasting. The median time before half the patients had progressed was about 4 to 5 months. Initially, based on lab studies, the thought was that this combination would work really well for T790M positive but not negative, but that's not what they saw. You can see these are these shades of gray, which is unfortunately the ambiguity of how it was published. You get pretty comparable results regardless of whether you're T790M positive or negative. One of the real challenges was this was a very difficult combination. When you combine these drugs that both have similar side effects, you just get more rash and more severe rash and diarrhea, and you're talking about 90% of patients developing a rash, sometimes a really limiting factor. So this was initially published years ago, and we've seen essentially nothing on it since then, which I would say is not a good sign. This is not borne out as a great option. Now, Tagrisso for patients with T790M was kind of a game changer. This doesn't include some of the updates that I put in. Sorry for the scientific names. This is Tagrisso. This is a drug called Ruxolitinib that kind of came off of research a couple of years ago. And these are third-generation EGFR inhibitors. And Nate talked about how the first generation ones come and go off of the EGFR mutant molecule, and the second generation ones like Giletrif, Afatinib, or Dacomitinib are irreversibly binding. These work a little differently by specifically being able to target T790M, and they also bind the first EGFR mutation, the ones that we consider the activating mutations 19 or 21. But they don't bind the wild type, which is the bystander, the skin or the gut or other things. And because of that, they have the potential and often the reality of hitting the intended target with fewer side effects. These are some of the other things that are being studied. They don't even have names, so that suggests that they're a little further behind. Tagrisso, or osimertinib, was studied in a very large phase 1 experience, like Dr. Shaw discussed earlier, with expansion cohorts, and wasn't just the safety. But here you can see they tested at various different doses. They found that they were all pretty well tolerated, and across a wide range of doses, a lot of tumor shrinkage, particularly in patients with a mutation-positive disease with T790M, and that was, really from lower than the standard FDA-approved dose, which is the orange, to higher than that. The side effect profile was less overall. You could see about a third of patients with diarrhea and rash, but very few patients with higher than grade 3, which is kind of mild and moderate to severe. This is the results of a trial that actually looked at comparing Tagrisso head-to-head with chemotherapy. So if you have T790M and you find that after progression, how does going on Tagrisso compare with doing chemo as an alternative? And the answer is, overall, progression-free survival is hugely better, 4 months and change versus over 10 months with Tagrisso. And also brain control was another major factor, significantly better with Tagrisso. So better overall control, better brain control. And so that just cemented the idea. We've had Tagrisso FDA approved for T790M positive patients since late 2015. I would say that the randomized trial compared to chemo was not necessary to Nate and myself. You had us at hello. We were convinced that was the way to go. But in some parts of the world, they needed to do that trial just to convince us. And it was exactly what we'd have expected to see, which is very clearly superior. What do we do for the patients with T790M negative disease? And it is ideal and routine to test at acquired resistance. One point is that patients with mutation-negative disease, you can have shrinkage. And this is the lower panel from the initial New England Journal paper showed that you could get tumor shrinkage in patients with T790M negative disease. It wasn't as likely. You can see that the more you are toward the left, when you see things go from going upward to going downward, that is a higher proportion of patients with tumor shrinkage. So nearly all patients with T790M positive disease see shrinkage, and a lot of them it's dramatic. You have a more variable, less convincing degree of shrinkage with T790M negative, but you definitely can. The problem is it doesn't last very long compared to the T790M positives, who can go many, many months before the cancer is progressing. T790M negative tends to last a lot shorter. And it may just be a kind of a last hurrah effect, because we do sometimes see, one of the questions that I've already seen come in is, can you go back to a drug that originally worked for you? And usually the answer is no. But sometimes you can get a last gasp of effect. If you go back to something, yeah, it'll maybe work briefly for a week or two before the cancer immediately compensates for that, because I saw you before, I know you. And the problem is that when we look at the T790M positives, these responses, the response rate 60 to 70%, doesn't matter whether you just got and came off of an EGFR inhibitor or you've been on other stuff for the last 6 months. It matters a lot more if you're T790M negative, where the response rate's quite low if you were just on an EGFR inhibitor. The response rate's much higher if you've been off of an EGFR inhibitor for months and maybe your cancer forgot about it for a little while. Then you can trick it a little bit and the response rate comes up about, to 36%. But then in short order, the cancer is already mowing over it. So that's a big difference, and that's T790M negative doesn't really get much of a benefit. So a key question when you have an effective agent that's approved for patients in this first-line setting is, second-line setting is, what if we give it first line? And so that's been tested. This is a trial of just 60 patients. 30 got it at 80 milligrams per day. 30 got it at the higher dose of 160 that's not FDA approved. And you can see it looks encouraging. The vast majority of patients have shrinkage of their cancer, and the time before the cancer comes back is about 19, 20 months, even in 22 in this. Response rate is very good, but that's about what we see with other EGFR inhibitors. And patients seem to be alive and without progression, potentially beyond a year, possibly 18 months. So is it better to give your best drug maybe up front and reduce the risk of the progression longer. That was tested with this trial called FLORA. First line is the FL, and AURA was the name of the series of trials that looked at osimertinib or Tagrisso. A little over 550 patients with an activating mutation, 19 or 21, and no prior systemic therapy. You could have received you could have an EGF brain metastases as well. And the randomization was to either first generation EGFR inhibitor, Iressa or Tarceva, called the standard of care, or Tagrisso first line. And this was presented at the presidential session, the biggest, most influential session of this big European meeting called ESMO that I was at last week. And a giant room saw this curve flashed and it changed things. This was also published at the exact same time in the New England Journal of Medicine, which is usually a signifier of this is going to be big and should change how we practice. It showed, a Kaplan-Meier curve with a big difference between the two curves. Standard of care did not do worse than they should have. It was 10 months, and that's about what we expect to see. But it was 19 months with Tagrisso, the yellow, and this so-called hazard ratio just is a measure of overall over the entire course of time, how much better did the Tagrisso patients do. They did about twice as well on balance. So you can ask, well, does it matter whether you're a woman or a man or older or younger, or whether you have brain metastases or not, or which kind of mutation you had? The answer was, no, it doesn't matter with any of those. In every one of these groups, the patients who were assigned to Tagrisso did better, and usually way better, about the same degree across the board in any way we could measure it. They looked at survival, and it was also an encouraging difference. Now, this is not a mature curve. That's good for everyone here, because that means more people are living a long time, and that makes it harder and takes more time to find out the impact on survival when just about everyone's living for years. That's great. So this was only at what's 25% maturity, so most patients are alive, but you can see the separation emerging and an overall 37% improvement. So the lower this HR, the lower this hazard ratio, basically the bigger the difference. And so that represents a 37% improvement in survival. And it was not what's called statistically significant because it was an early look, and you need to have a higher threshold to call it as significant. But it ain't bad. It's pretty impressive. On the limiting factor is there were patients on the standard of care arm who didn't cross over for whatever reason, because they weren't tested or whatever. And so that is a limiting issue. Could they do better if every single one of them got either Tagrisso automatically, or we ensure that every one of them got EGFR T790M tested and got it? They were only eligible if they were tested and found to be T790M positive. So some weren't tested. For whatever reason, some didn't get it. But it's a suggestion. And importantly as well, this was better tolerated. There was less rash, and there was a less of an increase. What's this AST and ALT are just blood measures of liver test problems. So fewer problems with the liver with Tagrisso than one of the other drugs. So it's not, and that is another factor, is the longer patients are on a treatment, the more chance you have to have side effects. So there's a bias against the drug that people are on for longer, because you just have more opportunity to get problems. And despite that, it was better tolerated. So that is potentially going to change things. But we don't have an approval yet. Now, a limiting factor as well is these were against first-generation EGFR inhibitors. The results might not be as significant against afatinib, Giltrif, or dacomitinib, or another approach that I've sometimes used, which is Tarceva with Avastin as a combination. But it's likely to be a very important trial. What else can we do? Well, I mentioned IPASS as well to highlight something a little different. It certainly is a critical trial, but one important point to make is that in the mutation-positive patients, this is an EGFR, not T790M, the response rate to chemotherapy was twice as high as it was in the patients who didn't have who didn't have an EGFR mutation. So, and Nate made this point earlier in the day, chemo is not a horrible consolation prize. I find it interesting that when people don't have a mutation and you start them on chemo and you say, your first treatment is chemo and that could help, people are like, great, I can't wait. When you tell someone who has been on a targeted therapy for a year or two that it's time for chemo, it's like the end of the world, and that's not true. It's just that it can still work quite well, and there's some evidence that it could even work better for EGFR mutation-positive patients. Not every trial has shown this, but it is definitely meaningful and worth pursuing. And at some point, it's, I think, valuable to stop going to the same well over and over again, and whether it's EGFR or ALK or whatever, and say, okay, well, now it's time to try a different approach. Speaking of another approach, can't turn on the TV without an advertisement about Opdivo or Keytruda, yeah, exactly, or hearing it on the news, and no question, it's hot stuff, but is it right for you? And I'll say that one of the key issues is that it's painful to have a patient with one of these driver mutations and a great targeted therapy available would say, I don't want these pills. I saw on TV I want Opdivo. No, not a good choice. And here's why. Because in the trials that looked at Opdivo versus standard chemo, Taxotere, most groups do better with Opdivo, except patients with an EGFR mutation. Those, not to say it's terrible, but they tend to be the outliers where the only people who it doesn't look that good in are the EGFR mutation patients. You could say, oh, that's one trial. But the same thing was seen with Keytruda as well. Every subgroup looks good except for the EGFR mutation positives. There can be exceptions, and I would say this doesn't mean you should never, ever, ever do immune therapy, but it does mean that it shouldn't be the top priority. That just, despite all the hype about it, this is where it is worth individualizing, and this is where it seems that the patients with the more mutations that are, the patients with a driver mutation, you really have one major thing that is driving the cancer, and that's the Achilles heel. With the other kinds of cancer, the ones that are more typically smoking related, it's not one thing. It's more of a lots of redundant circuits being taken down by death by 1,000 cuts. And that just makes it easier for the immune system to recognize. It's just harder to hit with one good stroke the way that there's a pill for EGFR. A caveat, one other option, there is a trial called Keynote 21, and 21G is what we usually talk about. And that looked at chemo with or without Keytruda added to it. It wasn't a huge study, but it actually led to an approval of this Keytruda as a first-line treatment for patients with non-squamous lung cancer combined with chemotherapy, regardless of regardless of PD-L1 staining. Now, you don't need to do it for this. That isn't to say that most lung cancer specialists have been captivated by it. It's small enough that we'd really like to see a bigger study show it. But certainly progression-free survival was way better overall for the combination given early. And the response rate was better, 56 versus 32% with chemo alone. The overall survival is not a significant difference, but there's a trend that has been getting stronger with longer follow-up. And so that is enough to make it certainly a reasonable option. I think that it is reasonable to think about doing chemo combined with immunotherapy. It's probably not wrong. It's just a consideration. I think one of the things that in general we struggle with is whether to combine or rush everything up front versus distribute our treatment options over time, as we hope people are going to have.
It's important to point out that that trial, if you look at the slide before this one, it did exclude anyone with an EGFR mutation.
Right. Now that's a great point. All of these first-line trials of immunotherapy exclude patients with a known EGFR mutation or ALK rearrangement. Why? Because the people who ran the trials in their heart of hearts knew that there's a clearly better choice with the pills, and they were not that confident that these drugs would look that good in that population. So this is not something I would be remotely enthusiastic about doing. Immunotherapy, I think the question is just, do you make it the last thing you do or before the last thing you do? But it's not the first thing you do. And thus far, we really haven't seen anything very promising of immunotherapy combined with the pill-based therapies. I wouldn't say never, but it's not something I would be inclined to recommend outside of the trial. So my conclusions of where we are now is Tagrisso is not FDA approved in first line, but it is likely to be soon. And it has greater overall efficacy as measured by the progression-free survival, better tolerability, and better control of brain metastases and protection against progression in the brain. That wasn't shown in the trial, but it's a remarkably effective drug in the brain. It's not perfect. More effective.
But importantly, in the FLORA trial, the progression-free survival was identical between those with and without brain metastases.
That's a great point. Yeah.
Almost always see a shorter time to progression in patients with brain metastases because those tend to progress first, and it didn't seem to be the case.
Exactly. So that's very impressive to have something that can neutralize that threat so well. So this is likely to become available to all patients. On the other hand, you don't have a sequential backup option. In terms of what to do after progression, which is a big question that a lot of us were tweeting about after this, is like, yes, but what next? Well, there was a time when we didn't have Tagrisso, and we need to go back to thinking in that way of thinking. One is that there's really nothing studied in EGFR-directed subsequent treatments. There will be, but we really largely have to think about chemo-based with or without immunotherapy, chemo followed by immunotherapy, and possible biopsy-directed options. Now, importantly, we don't know yet. This has only been in our world for a week. So and frankly, fortunately, most of the people who started on Tagrisso have been doing well and still are doing well. It's a new drug, only not yet 2 years, and lots of the people who I started on it are still doing great on it. So we don't have a lot of progression yet on Tagrisso, but we're starting to study that. We're seeing higher rates of MET, which is another mutation, that there are drugs for. One is approved. Crizotinib is actually a good MET inhibitor. It's not approved for that, but you can potentially do that. There's other clinical trials. There's another mutation in EGFR called C797S that makes it now potentially possible for a first-generation EGFR inhibitor, drugs like Iressa or Tarceva, to work again. So you may be able to do that. HER2, others are things that we're looking at. It is not yet standard of care to do biopsy testing at acquired resistance to Tagrisso, but it's a reasonable thing to look at, and we will only know more. Small cell, if you biopsy and find it, standard chemotherapy is also likely to have good activity, a really older standard chemo regimen. And then chemoimmunotherapy, as I said. So that's what I wanted to cover, and I know we have a lot of questions.
Yes. Actually, related to what you were just talking about, we had one come in. Based on the FLORA study, would there be a pro and con of someone on, let's say, Tarceva switching to Tagrisso with no sign of progression?
Yeah, I think that's kind of the million-dollar question that Nate and me and lots of other people are facing is, what do you do? I think my inclination is toward making a change, because I think there's a chance that, first of all, the better brain control, and that you will slow resistance enough that it overall leads to a better outcome over the entire course of treatment for a patient, multiple lines. And the overall survival benefit may or may not prove to be meaningful. I mean, I think the curves may well come together, and I think it's not ideal that the crossover is not as much as we'd like. But one of the big advantages of, just like Nate said, about if you find someone who has an EGFR mutation, putting them on the EGFR inhibitor early is, at least you ensure they get a very effective drug, and nothing's going to come between them and that drug. And I would say the same thing perhaps about Tagrisso, that it's a better drug. You could do a sequential approach, but if they do develop bad brain metastases and end up in a wheelchair and unable to swallow or something, it's not likely, but bad things could happen. Or if they develop T790M negative disease, that may not be best in the long run. It would be maybe better if you know someone's going to be T790M positive to sequence them, but we can't know that right now. And so my general inclination is going to be to switch. I would say there's a role for a patient's decision if they feel like, no, I really like having that available as a backup plan. Okay, and I wouldn't twist their arm about it. I would be swayed, particularly in the patients who are doing well at 2 years and 3 years on Tarceva and not having side effects, say, okay, that's pretty good. But because I think quality of life is, I have other patients who every day of, they have these annoying, if not prohibitive side effects, and reducing those side effects would also be a benefit. So that's my view, but I think it's a total judgment call that even with me as the same doctor, I would have a different perspective with some patients than others, and the patient's perspective counts too. What do you think?
Yeah, I think, so I definitely believe that Tagrisso should now be the treatment for basically everyone at first line. I think that's impressive enough, and the lack of side effects is impressive enough that I would now recommend this as my first initial treatment for just about everybody. For people who are already on, say, Tarceva, for example, or Gilitrif, if they're having trouble with side effects and they're managing them but they don't like them, I think that would be a good argument to consider switching now, because you have some evidence that you might actually be helping them in addition to better side effects. People who have brain metastases that have required treatment, or people who have asymptomatic brain metastases that we're just watching every few months on Tarceva or Gilitrif to see when they may start progressing and we might have to treat them, is another situation where I think it would be worth switching. But and people who I just started, so we just learned about this last week, but people that started, say, 3 weeks ago, I think it might be worth calling them in and asking whether it's, it would be worth considering making a change. But for people who've been on Tarceva or Gilitrif and tolerating it well and having a good quality of life and with good disease control for a long time, 6 months, a year, certainly my people who I've had who have been on it for multiple years, I'm not going to routinely recommend that they make a change because they already seem to be benefiting from what they're on. And I'm also very good about, and all of our group here and many places are good about making sure that we really look for T790M when they start to progress. So I'm not convinced that you're necessarily, I think much of this benefit is that you're just not missing everyone, as Jack said. You making sure that they have access to that drug. But if you do guarantee that everyone who is eligible for it, who has T790M, I'm not sure that I'm convinced that they're not going to get an equal amount of benefit from being on the first generation and then the second generation or the third generation afterwards, as long as you test for it, find it, and give it to them at that point.
Awesome. A bunch of questions about the Chimomax vaccine. A lot of people are asking about that, of course. Simomax. It's, the Cuban vaccine.
That they're testing in the hospital.
Yeah, so there's been like 3 or 4.
Yeah.
It's a hot topic, so if you guys want to touch on that.
Yeah, I'll say.
Sure.
I think that is not among the top 1,000 promising ideas. I think that is the definition of more sizzle than steak. I sat on a panel a few months ago with someone whose family's from Cuba. He goes back and he says, "Don't believe anything from Cuba." And I would just say that the benefit that we've seen with that is very equivocal, marginal, and the first publication on it was for like 2008 or 9. I wrote about it on Grace, 7, 8, 9 years ago. And I thought, yeah, it looks interesting, but it's like a 2-month difference. And in all of that time, with all of the people being treated, it hasn't amounted to anything. I can't convey how minor of an issue it is to the true watchers of the field. It just has never come up to the lung cancer specialists because it's, I think, a non-entity that is just incredibly fascinating to the media, the mass media, which has largely duped you, I think, unintentionally, because they don't know what they're talking about. And I think that it's really, I'm obviously, I have my biases, but I think it is not among the more promising ideas.
The conference is about to end.
How little I would be inclined to have you spend money to privately pursue it. It's, ugh.
So, with all respect, I'm going to be less wishy-washy about this. When the reports first started coming out about the Cuban vaccine, the Simovax, there was a lot of media attention that, oh my gosh, there's a vaccine for lung cancer and they're using it. It's not just experimental, they're actually doing it. And my first reaction was, well, you know what? We have vaccines too. They just didn't work. It's not that we didn't try them, it's not that they didn't work for exactly what they were intended to do, which is raise immune response against the cancers. They did. Actually, we have multiple trials where you inject a vaccine into patients with cancer and you look and you find T cells that are actually activated by that vaccine. But the problem is the cancer continued to grow. And that is the fundamental problem with immune therapies, is that, cancer is protected against your own immune system. That's the whole rationale behind these new drugs like Opdivo and Keytruda, is they kind of remove that protection of autoimmunity of your immune system attacking your own self or your own cancer. So it is very possible that a vaccine plus a drug like Opdivo or Keytruda, and I think that actually is the trial at Roswell, they're not doing it by itself, they're combining it, that may end up being a very effective treatment. I don't know whether this vaccine will be the right one, but I do think it's a very promising field in combination. But by itself, I certainly would not recommend anyone fly to Cuba to get the drug by itself, because I bet it doesn't do anything at all.
Well, and let me backpedal a bit, because I agree. I'm all for doing the trials. And again, I am happy that we don't know everything there is to know, and we will continue to improve on that. I mean, I think it's great to say, I thought something and new information came and now I'm happy to be wrong. I think it's great to do the trials. I just don't like when anything gets where the hype goes ahead of the data, whether that is a diet or a novel therapy, whatever, and whether it comes from a naturopathic place or from the lab at Merck. It doesn't matter. I just think, let's just see what the evidence shows. All for that. And just because we didn't see something blow out the barn doors as a single agent doesn't mean it won't be good in combination with immunotherapy. I agree with you. If there's any setting where I think it could be different and better, it would be, that's different. So I don't want to throw out the baby with the bathwater. I would just say, don't book your tickets to Cuba, basically.
Right.
And somebody also asked, I saw about Vaxira, and I don't know. And I think these are all, there's other things that are going to be tested. Great. I would love to see. I just don't think, I wouldn't have this fear of missing out on the next great big thing just because there's a trial being done on it. There's fortunately dozens to hundreds of trials being done. And,
Many hundreds.
Yeah, and I would not presume they're all right.
Can you talk more about protection after Tagrisso, is it standard of care right now to do a new biopsy? And are there trials that are showing any promise, or that we're getting close to, like we saw Tagrisso with a couple of years ago, for people who develop resistance to Tagrisso?
Right. So as Jack said, this is a very new field with Tagrisso, and so we don't yet have the same big groups of people who've developed resistance that have had biopsies, that have been analyzed, that are published the way Dr. Shaw's group was famous for publishing these big pie charts and in New York, where they have hundreds of patients who progressed on the first generation EGFR inhibitors and did biopsies, and they could say clearly, half the people had T790M and 8% had small cell. We've got really anecdotal individual cases, or a few cases of this for Tagrisso. I would say in 2017, if you're on Tagrisso and you progress, it is not the standard of care off of the clinical trial to do a biopsy for everyone for that situation. There are situations where you might. Really fast and unexpected progression, I might suspect small cell.
But when you looked at the subset of patients from this big unselected study, the never smokers, Asian patients, and in one of the studies, mutation-positive patients, were the group that seemed to get a benefit from the combination. And I definitely kind of latched onto that and ran trials for never smokers or patients with bronchial-alveolar carcinoma, two groups that are enriched for mutations, but is not the exact same thing, and looked at the combination. And its short answer is these patients generally did quite well with it. The big excitement was that there was a Japanese study that randomized 152 patients to either Tarceva with a mutation, to either Tarceva or Tarceva Avastin, and the Tarceva Avastin combination had a very significantly better progression-free survival, 10 months versus 16 months, and it actually was approved by the European version of the FDA, and is used in Europe. I have favored that. I don't think it's a fluke. I think it's real. And I've been doing that for a lot of my patients, many with great success. But it hasn't caught on in the U.S., I think, for multiple reasons. It wasn't a giant study. It was Japanese only. And I think some of it has been that there just wasn't as much of a compulsion to change from Tarceva, which did pretty well, as much as to change from chemo to Tarceva. But I think it's largely bias and xenophobia and all sorts of things that have limited it, because part of it is, yes, these are Japanese data, so we can't believe it. But Nate showed it was Japanese studies that first showed this big difference in chemo versus Tarceva or Iressa initially. These were also 200 patient studies out of Japan, and the national experts decided within 10 seconds that the new standard of care would have to be Tarceva, which wasn't the same drug tested, based on Japanese data. So they sniffed about the quality of the Japanese data on Avastin Tarceva, but not here. I just kind of got tired of beating my head against a wall, and it's something I would still offer to some patients, but not all. It just didn't catch on for whatever reason, and I think the world's moving on anyway. But I think there is something real there, that patients getting these angiogenesis inhibitors, that Avastin is one of, blocking the blood supply of the tumor, may well provide a meaningful benefit for EGFR mutation-positive patients. And I hope and expect that we'll see some work with Tagrisso combined with EGFR.
I'm sure we will. Yeah, I'm sure we will. So, Avastin basically improves the progression-free survival of anything you add it to. It's successfully prolonged PFS in everything. Any chemo regimen it's been added to. Most of those regimens have never led to any meaningful difference in overall survival in these clinical trials, so helping people actually live longer. But it does seem to extend the amount of time that treatments work before they stop working. So the reason I haven't broadly adopted Tarceva plus Avastin based on this trial was not so much that I didn't necessarily think that it worked. I believe that it probably does prolong progression-free survival, but I didn't see anything that made me think that it was necessarily helping people live longer. And I was bothered by the idea, and I would love to hear actually this group's opinion about this. I was bothered by taking someone that is on a daily pill, and I only have to see them every 3 months, and suddenly saying, now I want you to come in every 21 days, get an IV put in, or a port, and get a treatment. And then, we're also probably going to have to put you on a blood pressure medicine because you're going to get hypertension from this medicine. And oh, by the way, there's also a risk that you might have fatal bleeding in the lungs or a bowel perforation or, clotting and things that can occur with these medicines. But the Tarceva may last another 6 months beyond what it would anyway, even though we don't know that you're going to live any longer for that. I phrased it in a kind of a biased way, but is that meaningful to you? If someone were to tell you, when they looked at the people in this trial, people didn't live any longer, but it did delay the drug stopping working, but the trade-off is some side effects and less convenience. I mean, is that something that I'm sure it's different from person to
Well,
person.
I think,
Yeah.
it's a great point. I know we need to run.
And we're running out.
We'll have people answer. But then again, the difference is, when we adopted Tarceva, it wasn't based on living longer. It didn't bother anybody about that.
No, that's true.
And the difference between my patients love seeing me every 3 weeks.
Nobody loves driving to Cleveland every 3 weeks.
So for me, that's just part of the appeal. It's really an excuse to see me.
I only drive every 3 months, 2 hours to see them.
Yeah, so there you
I
go.
have one question. On that survival issue, do we know there's no improvement on the survival, or is that just not known?
It actually was way too early. The report on it was, the publication was when still 80-90% of patients
That
were
was
alive.
years ago now, though. Have they ever updated it?
I think they did, and it was more different, but it was not in a large form.
It's one of these things where I was waiting for a bigger trial to replicate it in a larger number of people, because as Jack said, there was only 75 people in each group that did it. So, but it has never been repeated in a larger trial.